Very good afternoon. Greetings from Bangladesh. At the outset, I must thank to the organizers of the All India Ophthalmological Society for giving me the opportunity to discuss what I think is extremely important related to the world of refractive surgery SMILE and particularly on the pearls for optimizing its outcome. I have no financial disclosures. As you know, small incision lenticule extraction has been evolved as a flapless, bladeless, orderless, minimally invasive, cornea-based, all femtosecond laser intrastromal refractive lenticule extraction procedure to treat myopia and myopic astigmatism. SMILE has brought a paradigm shift in the field of laser vision correction from the conventional flap-based corneal ablative procedure to a corneal intrastromal refractive lenticule extraction procedure. The evolution of refractive surgery dates back in 1949 when none other than the father of the modern refractive surgery, Professor Jose Barraquer from Spain, brainchilded the conception of keratomylosis, which saw the light in 1963 when for the first time he published his work on keratomylosis based on the fundamental principle that the cornea contributes 2/3 of the total refractive power of the eye. So what is behind the evolution of refractive surgery? Well, if we evaluate all of these procedures, PRK, LASIK, femtolasic, SMILE, you will see that over the time these procedures have become more safer, more accurate and more predictable. The dream of Dr. Jose Barraquer came true in 2008 when Professor Dr. Segundo first described the extraction of an intrastromal lenticule after lifting a flap, and eventually the technique evolved into modern small incision lenticule extraction. Although historically Dr. Segundo performed the first SMILE in 2008, the first commercial sales of SMILE began in 2010 and US FDA approved SMILE in 2016, and by 2018 more than 1 million procedures were performed around the globe. The perceived benefits of SMILE includes greater corneal biomechanical stability, better conservation of corneal nerves, less induction of dry eye, no flap-related complications, less induction of higher order aberrations, better refractive predictability, and no need to change from one station to other. Different meta-analysis in the literature, various randomized and non-randomized control trials have shown that in terms of refractive outcome, particularly as far as the efficacy and predictability is concerned, both SMILE and LASIK are comparable. And if we look at the corneal biomechanics, we know that the anterior 150 microns of the corneal stroma gives more strength to the cornea than the posterior 300 microns. And different studies have shown that SMILE is biomechanically stronger than LASIK. Various studies to assess the corneal biomechanics using an ultra-high-speed Scheimpflug camera, Corbis ST, have shown that SMILE is biomechanically stronger than LASIK, but PRK ranks the top. As has been reported in various literatures about SMILE ectasias, preoperative workup, as with other refractive surgical procedures, is extremely important, particularly Kmax, Pachy at the thinnest location, the front and the back elevation maps, the Belin-Ambrosio enhanced ectasia display, particularly the progression index and the final D. Now I routinely perform the combined Corbis ST values with the Pentacam values, which gives me an overall combined tomography and biomechanical assessment of the cornea, particularly CBI, BAD-D and TBI. The other issue is the relationship of SMILE with dry eye. Basically, SMILE results in minimal cutting of the anterior corneal nerves and therefore induces less dry eye symptoms in terms of tear breakup time, corneal subbasal nerve density, corneal sensitivity, OSDI score, overall patient comfort, and tear osmolarity. Now, as far as the relationship between higher order aberration and SMILE is concerned, various studies have shown that SMILE induces lesser amount of total higher order aberration and spherical aberration in comparison to LASIK. SMILE involves a number of standard techniques such as docking, femtosecond laser applications, lenticule dissection, and lenticule extraction. During femtosecond laser application, essentially 4 cuts are made to create the lenticule. The first cut is the lenticule cut, the second cut is the lenticule side cut, third cut is the cap cut, and finally the cap opening incision. While docking, patient is encouraged to look at the green flashing light. When centration is confirmed, suction is activated. The first cut is the lenticule cut in a spiral in pattern, followed by the 360-degree lenticule side cut, followed by the cap cut in a spiral out pattern, and finally the cap opening incision. Anterior plane is delineated on the left side and the posterior plane is delineated on the right side. By taking the Dan dissector, anterior plane is dissected first, in a windshield wiper fashion. Then the posterior plane is dissected in a sweeping motion. The separated lenticule is extracted with the help of a microforceps and is checked for its completeness. Corneal interface is flushed with BSS and tapped with the spatula to check for the addition with the help of the slit lamp attached with the VisuMax laser system. We published our initial experiences and data in the Bengal Ophthalmic Journal and in the Journal of the Ophthalmological Society of Bangladesh in 2019. And we encountered few complications such as suction loss, opaque bubble layer, black spots, difficult lenticule dissection, difficult lenticule extraction, incisional tear, cap lenticular adhesion, and epithelial defects. And in the study we found, as the surgeon gets experienced, the number of complications got reduced in last 100 cases in comparison to the initial 100 cases. So what I think for easier transition from flap to cap is observation of a smile by the experienced surgeon, which is very, very important. The another important thing is initial wet lab training, and one needs to start with femtosecond lenticule extraction or flex, then converting to pseudo smile, then smile through 4 mm side cut, and finally smile through 2 mm side cut. In flex, both the lenticule and the cap is created, and the cap is converted to a flap, and the lenticule is extracted by an open sky procedure. Suction loss may occur in an anxious, uncooperative patient due to sudden movement or squeezing of the eye or due to excess fluid around the cone. If the suction loss occurs in a situation of less than 10% lenticule count, or during lenticule side cut, or during cap cut, or during cap side cut, it is better to redock and repeat the procedure. This is a patient who came for a smile. The patient was highly apprehensive, anxious because of the sudden squeeze. He developed a suction loss. Then the patient was subsequently converted to a femtolasic by taking a larger size cone with a larger corneal flap diameter, and subsequently femtolasic was done, and patient has an excellent visual outcome. Black spots may result from inadequate laser delivery in a localized area due to the entrapment of the small air bubbles, water droplets, or any debris between the patient's interface and the corneal surface, which leads to microadhesions and difficulty in dissection of the plane. This may be prevented by adequately weighting the cornea before docking and avoiding any debris on the ocular surface as well as on the patient's interface. OBL can be observed in cases with too high or too low laser energy settings, and they are common in thicker corneas and thinner lenticules. These leads to microadhesions and creates resistance to dissection. So optimization of the energy setting is very, very important in this type of situation. There are situations when inadvertent dissection of the posterior plane first before the anterior plane results in cap lenticular adhesions where lenticule gets stuck to the undersurface of the cap. Blunt hook side of the spatula is used to identify the lenticule edge and to create a plane between the overlying cap and the lenticule, or to peel it off from the undersurface of the cap. Incisional tear may occur due to excessive surgical manipulation by the inexperienced surgeon. One should avoid forceful lenticule dissection and extraction by using bulky instruments. Frequent lubrication by artificial tears and use of bandage contact lens usually take care of the problems. Again, epithelial defect may result from excessive surgical manipulations and frequent use of topical anesthetic eye drops, and this can be taken care of by frequent use of lubricating eye drops and putting a bandage contact lens. There are situations when difficulty in lenticule dissection may rarely lead to retained lenticule fragment, which may be confirmed by ASOCT. Smile has its limitations as well. Myopic sphere cannot be corrected beyond -10 diopter, and cylinder up to -5 diopter can be corrected. Equipment and consumables are expensive. Automated cyclotorsion compensation is not available. Hyperopia correction is not available at present. Newer advances in smile are on the way. Newer lasers from newer manufacturers having hyperopic treatments, presbyopic treatments, cyclotorsional treatments, and faster lasers with almost free floating lenticules. So my take-home message is, from flap to cap is always challenging for the beginners in smile as well as for surgeons experienced in performing flap-based corneal ablative procedures. Intraoperative complications during smile are mostly observed in initial cases. As the surgeon gets experience, the chances of complications become less. right patient selection, proper docking, optimizing energy levels, meticulous surgical technique, and early recognition with proper management of complications is fundamental for optimizing the final visual outcome in SMILE. Thank you for your kind attention.